In classrooms all over the world, there are children whose learning is hampered by visual processing problems. Although the most common name for these difficulties is visual dyslexia, other terms such as visual stress, scotopic sensitivity and Mears-Erland syndrome have been used to describe some of the symptoms reported. This DVD has been created in association with Ian Jordan, a leading UK optician, to enable you as a parent or teacher to learn about the visual perceptual difficulties experienced by around 1 in 10 children.
Your optician, your psychologist, your occupational therapists, if they're not an expert themselves, they should know somebody they can refer you to that actually does have significant levels of knowledge. A simplistic test for using things like overlays is not adequate. You must have a test which incorporates all the senses.
The text itself may appear to change in size or thickness, or may even appear to fall off the page.
These are EEGs of a normal child. On the right hand side, you see what happens inside the brain when the eyes are open. The brain is uniformly aroused. When they close their eyes, on the left side, the occipital cortex, the back part of the brain, becomes aroused even further, but this is a pre-sleep mode. In the dyslexic child, even with their eyes open, they go into a pre-sleep mode, as you can see by the occipital cortex. This means they cannot possibly process information properly. This has to be addressed before they can address the curriculum. And so in the second EEG on the right hand side, using lenses, the visual areas now become normal and allow the child to process the information properly. This means the best teacher in the world cannot address visual dyslexia unless they address the visual input problems. Visual expression may be poor. This is a particular problem in autism, Asperger's syndrome, and for those with dyspraxia. Right, looking at my face, how much of my face is clear? Look at my nose, the tip of my nose.
It's just really your nose that's clear.
When I move my face, what happens then?
It's still just your nose, the rest is quite blurry.
Right. Could you change the colour, please?
It's still just your nose that's clear. It's still just your nose.
Again. Now?
A lot of it's very blurry. I'm finding it hard to concentrate on your nose.
Okay. Now?
Your eyes and your mouth seem to come together. It's looks like a face now.
So before it didn't look like a face?
Yes.
So you can only see my face clearly in red?
Yes.
When I look at people's faces, I'll maybe concentrate on one eye, but I don't seem to see anything else around it. I'll just see a slight blur, that it's not in focus. When I put on the red glasses, everything comes into focus. I'm able to point out 2 eyes, a nose and a mouth, and it makes the whole face a lot clearer.
Alternatively, colour and illumination control may be used by many practitioners. Early professional colour interventions used overlays, simple broad spectrum lenses and subtractive assessment techniques such as trial and error. These methods have some serious drawbacks, and modern additive methods where specialist lights are used for determining the optimum lenses have taken prescribing to a whole new level. Techniques such as the orthoscopics system, which was developed as an improvement to the earlier systems, use methods which mimic the retinal responses of the eyes and use new types of tinted lenses, which means that the results that can be achieved in visual processing have been greatly improved. It is not possible to prescribe colour for clinical or educational purposes without a great deal of knowledge. It may appear simple, but it is extremely complex.